Elder abuse. It can occur to anyone 60 or older. And every year, as many as 10% of elderly Americans endure some form of abuse, neglect, or exploitation. They're targeted because of age, disability, vulnerability, or by someone they know, someone in a position of trust. Victims of elder abuse suffer medical consequences, an increased risk of depression, worsening chronic illness, even death. While abuse often happens behind closed doors, there are signs for clinicians to identify if we know what to look for. But more often than not, we don't. National research suggests that ED clinicians almost never diagnose elder abuse. Not physical abuse, not psychological, not sexual, not neglect, and certainly not financial exploitation. We just don't see it. As a result, during every shift, the victims who suffer these abuses hide in plain sight in our ED waiting rooms and on our stretchers because we're missing the mistreatment. An ED visit for an acute injury or illness may be the only time a mistreated older adult ever leaves their home. Many victims don't have primary care providers. Even for those who do, a broken bone or worsening of congestive heart failure brings them to us. We have the opportunity to help, but once they're inside our doors, most clinicians focus on only a piece of the older person's narrative. We treat the medical complaint without identifying that these elder patients are, in fact, victims. Why are our emergency rooms failing this vulnerable population? There are actual time constraints to conduct a thorough evaluation, and there's a desire to avoid involvement in the legal system. And patients themselves, or others at the bedside, may deny mistreatment or even conceal evidence by insisting that it was only a fall, instead of confiding that it was abuse. But while these very real barriers exist, there are other reasons for our failure to recognize the victims of elder abuse, and they come down to culture and knowledge. Clinicians aren't responding to the signs of elder abuse because of a lack of training, a lack of a solution, an absence of protocols, or for no other reason than they just don't want to know. Dealing with the intricacies of elder abuse is extremely challenging. But we already have an effective model in place that provides positive outcomes. The prevention of child abuse. The ED is the primary site to identify cases of child abuse, and it can serve the same purpose for the elderly population. But this means we need to view the injuries that elderly patients suffer with the same level of suspicion currently reserved for a child presenting with physical trauma. The ED is uniquely positioned to serve this vulnerable elderly population and to help those victimized by abuse. ED resources are available 24/7, and emergency departments have the very disciplines to take advantage of the prolonged evaluation process and to thoroughly investigate patients for signs of abuse. In fact, with so many eyes on the patient, from EMS, triage providers, patient escorts, nurses, radiologists, social workers, and case managers, we have the collective ability to discover the evidence of elder abuse. Elder abuse erodes quality of life, and its victims suffer social isolation. Currently, these vulnerable older adults pass through our emergency rooms unseen. As ED clinicians, we can change that. We treat their medical problems. Now we need to stop their suffering. Elder abuse can stop here because recognizing it starts here. Was your fall really a fall? Is anyone trying to harm you?